Diagnostic tests have characteristics termed sensitivity and specificity. Sensitivity is the ability to detect true positives, specificity is the ability to detect true negatives. Even a very good test, with 95% sensitivity, will miss 1 in 20 people with the disease. Every test therefore generates false positives and false negatives. Box 1.4. A very sensitive test will detect most disease but may generate abnormal NDings in healthy people. A negative result will therefore reliably exclude disease, but a positive result does not mean the disease is present, it means further evaluation is required. On the other hand, a very specific test may miss significant pathology but is likely to establish the diagnosis beyond doubt when the result is positive. All tests differ in their sensitivity and specificity, and clinicians require a working knowledge of the tests they use in order to accurately interpret them. In choosing how a test is used to guide decision-making, there is a trade-off between sensitivity versus specificity. For example, Denning an exercise electrocardiogram, page 393, is abnormal if there is at least 0.5 mm of Saint depression would ensure that very few cases of coronary artery disease are missed but would generate many false positive results, high sensitivity, low specificity. On the other hand, a cutoff point of 2.0 mm of Saint depression would detect most cases of important coronary artery disease with far fewer false positives. This trade-off is calculated using the receiver operating characteristic curve of the test Fig. 1.4. An extremely important concept in clinical decision-making is this: the probability that a person has a disease depends on the pre-test probability, and the sensitivity and specificity of the test. For example, imagine an older woman has fallen and hurt her left hip. On examination, the hip is extremely painful to move and she cannot stand. However, her hip X-rays are normal. Does she have a fracture? The sensitivity of plain X-rays of the hip performed in the emergency department for suspected hip fracture is around 95%. A small percentage of fractures are therefore missed. If our patient has or is at risk of osteoporosis, has severe pain on hip movement and cannot bear weight on the affected side, then the clinical probability of hip fracture is high. If, on the other hand, she is unlikely to have osteoporosis, has no pain on hip movement and is able to bear weight, then the clinical probability of hip fracture is low. Doctors are continually making judgments about whether something is true, given that something else is true. This is known as conditional probability. Bayes' theorem, named after English clergyman Thomas Bayes, 1702–1761, is a mathematical way to describe the post-test probability of a disease by combining pre-test probability, sensitivity and specificity. In clinical practice, doctors are not able to make complex mathematical calculations for every decision they make. In practical terms, the answer to the question of whether there is a fracture is that in a high-probability patient a normal test result does not exclude it, but in a low-probability patient it virtually does. This principle is illustrated in Fig. 1.5. Sachs and colleagues c. Further information state a fundamental assertion, which they describe as a profound and subtle principle of clinical medicine: the interpretation of new information depends on what you believed beforehand. In other words, the interpretation of a test result depends on the probability of disease before the test.